Hi, my name is Daniel Gessner. I'm a regional anesthesiologist here at Stanford. Today we're going to be talking about erector spinae plane or ESP nerve blocks. We're going to talk about what they are, we're going to talk about when we do them, and we're going to talk about how we do them. So, learning objectives. Today we're going to talk about what is the erector spinae plane block. We're going to talk about what is the evidence for the block, and we're going to talk about how people think it works. And then we're going to talk about when and how we do them at Stanford, and then also how we manage them at Stanford. So I think it's important to realize that these blocks were only first described in 2016 in this paper on a case series of patients who had chronic pain in their chest wall. So this first patient had what was eventually realized to be a lytic lesion on their rib that you can see here, circled in yellow. And they got a series of injections superficial to the erector spinae muscle near their site of pain. And you can see that they included dye in the injection, and this is a CT image of the dye spread. And they had reproducible cutaneous anesthesia covering the chest wall in the front and the back, and improvement of their pain. And you can see in this diagram that the 1 corresponds to where this first injection was done, or where these series of injections were done for this patient, superficial to erector spinae, which is different than how we do it at Stanford. Their second patient, they first attempted injecting superficial to erector spinae, but didn't have very much success with pain relief. So the second time they injected deeper to erector spinae at where the transverse process is, which is where we do them at Stanford now, and where most people do erector spinae blocks now. And that patient, once they did that, they then achieved similar dense cutaneous anesthesia. And then they did some injections in cadavers with methylene blue against the transverse process. And they showed dye spread in the direction of both the dorsal and the ventral rami of the spinal nerve roots. And they proposed that the mechanism of this block was indirect spread of local anesthetic from the injection point, lateral to the transverse process, down towards the spinal column. Not getting to the spinal column, but getting to the ventral and the dorsal sensory roots at each spinal nerve level, causing cutaneous anesthesia both anteriorly and posteriorly. This case report really inspired a lot of work since 2017. This is a graph of the number of citations in the Web of Science of that case report article since 2017, and there's been thousands. And just a quick kind of overview. So initially, people started doing these blocks and reporting that it seemed like in cases you could get some visceral coverage of pain, so it wasn't just chest wall, it also seemed to have some visceral component. It seemed to work okay for thoracotomy in case reports. It seemed to be able to cover the abdominal wall if you did it a little bit lower, again in case reports. And also cover laminectomies, which makes sense because that's posterior. It worked in rib fractures in case reports, it worked in shoulder pain, it worked in total hip arthroplasties. In 2018, the first complication was reported, which was a pneumothorax, which kind of makes sense. Then there were competing cadaver studies in early 2019 that started to argue about whether or not there was spread to those ventral rami or to the paravertebral space, which is considered to be the mechanism by which you would get anterior analgesia. And then some randomized control trials started coming out saying that it was opioid sparing in breast surgery, it was analgesic in sternotomy, it was analgesic for lap chole, and then a review article published out of Stanford demonstrated that relatively few patients had sensory change, which doesn't really fit with the proposed mechanism of the nerve block, because you would expect there to be sensory change if the nerve block is spreading to those dorsal and ventral rami. And another local RCT here at Stanford that showed it was non-inferior to inner scaling, and then also a a cohort study showing it was analgesic for rib fracture. So a lot of excitement about this block, a lot of evidence developing. And then sort of going back to more case reports. So in 2018, there's a case report that demonstrates somewhat of like the holy grail of all this, which was epidural spread from an erector spinae plane block, demonstrating that this could be like a sort of indirect way of doing an epidural, which was a very attractive thing for a lot of people. So a 2021 review article by Chin et al. Reviews all the possible mechanisms for analgesia from the erector spinae plane block. They conclude that direct spread to neural targets is, quote, the most plausible mechanism for analgesia. And based on multiple cadaver studies, they conclude that the most likely targets would be spread to the branches of the dorsal rami, which would innervate the back of the body. And many of those branches live within this erector spinae muscles. So you can imagine how that is a very plausible mechanism. And then also plausible would be spread more ventrally towards the front of the body, which would cover spinal nerve roots, the ventral rami of the sensory nerves, which would cover the front of the body, and then maybe, for instance, the brachial plexus, which is why you get some analgesia for shoulder surgery. Less likely, they say, would be spread to the paravertebral space and the epidural space, which has been seen but not consistently and not in necessarily high enough volumes or high enough doses to actually result in analgesia. Secondly, they consider whether or not the systemic effect of injecting a large amount of local anesthetic and then running an infusion into a muscle just achieves a meaningful plasma concentration. And they consider that to be plausible but, quote, less likely as the mechanism for the analgesia. And then there's some more speculative options. One is a consideration that maybe that spread that people are seeing in the epidural space doesn't represent actual epidural spread, but more represents spread via lymphatic uptake in living patients into the lymphatic system, and that maybe the local anesthetics could interact with lymphocytes in the lymph nodes around the spinal column and exert some sort of immunomodulatory or anti-inflammatory effect, which could reduce pain. And they conclude that is not entirely improbable. Then the most speculative would be that there's some sort of, as of yet, undescribed or undiscovered innervation in fascial planes, something important in fascial planes, maybe somehow related to acupuncture meridians or something like that. But they consider that to be speculative and that there's no specific evidence for it. So as of 2021 at Stanford, we think that ESPs are worth considering for anesthesia anywhere on the trunk, including the shoulder and the hip. We think that they're very low risk. However, it's important to remember that pneumothorax and local anesthetic toxicity are always possibilities, particularly when you're injecting large volumes of local anesthetics into muscles. But we also don't think there's any absolute contraindications. So we're not particularly concerned about anticoagulation, for instance. And then importantly, we do not expect a sensory level. And then we also do not expect a sympathectomy. But that also would mean that it will not function as a primary anesthetic. This is only an analgesic block. And then trying to contribute to this work, we do have an ongoing placebo-controlled randomized trial called Regional Anesthesia for Cardiothoracic Enhanced Recovery, which is comparing lidocaine infusion to placebo in cardiac surgery. So at Stanford, we approach this procedure in a pretty standard fashion. I really like this image from this paper that's cited below. So basically you can see that if you scan with your ultrasound probe oriented up and down towards the head, and you scan over the spinous processes, you'll see what's highlighted here in blue, which is spinous processes. And as you move your probe out all the way to the ribs, you can see these really clear ribs. And then as you move back towards the midline, eventually the ribs will go a little bit deeper, and then you'll see transverse processes. And then we try to inject with the needle, just touching the transverse process, dissecting the erector spinae muscle off, and then putting the catheter in. And you may see us use these e-caths, which are catheter over needles, which we think may, in some circumstances, more favorably enter the fascial plane as compared to using our standard arrow catheters. I think it's really important, though, to remember that the erector spinae muscles are not one cohesive group of muscles. This is not like the rectus sheath, for instance, where it's a fully enclosed fascial plane of just kind of one muscle. The erector spinae muscles, there's a lot of them, and they insert variably with all these little fingers on each little rib and each transverse process. So it's not like there's going to be one clear fascial plane. Try to not think about this as just one obvious muscle that you will definitely get underneath and then float up and then thread a catheter and it's going to be great. There's a lot of variable insertion points in the erector spinae muscles, and there's a lot of striation and a lot of different muscles back here, and it's not as straightforward to put a catheter underneath it as you might imagine it would be. And then in terms of dosing here at Stanford, for most cases we will bolus ropivacaine 0.25%, kind of an analgesic dose. We aim for 2 milligrams per kilogram total. So for a 60 kilogram patient, that would be 25 milliliters of 0.25% ropivacaine on each side. And then we typically these days infuse lidocaine 0.5%, 15 milliliters every 120 minutes, and we try to stagger them so that each side gets a dose every 60 minutes. So I think the biggest takeaway points about the ESP block here at Stanford is that they may be beneficial, but importantly they seem very safe. And we have not had any significant complications at Stanford from ESP blocks. We place them deep to the erector spinae muscle at the transverse process, but honestly, it's not entirely clear why it's important to place them there. And then ESP blocks may provide analgesia and opioid sparing, even if they don't have a reliable detectable sensory change. And this is an exciting block. It's one of the blocks that's probably going to be the future of regional anesthesia. We're really excited to do them. We're really excited for you guys to do them. But there's still a lot to learn about them.